Welcome now to this live broadcast that will see the Minister of Health, Dr. Jane Ruth Aceng, address the press today in regards to COVID-19. And soon or later, we'll be taking you there to see what she has to say in regards to COVID-19. Currently, as we talk now across the region, Kenya has about 262 cases of confirmed cases of COVID-19, and among these, 11 have died and 53 have recovered. In Tanzania, we have about 147 cases of COVID-19, 11 have recovered and 5 died. Rwanda has 143 confirmed cases of COVID-19 and 65 have recovered, and in Rwanda, no one has died from the virus. As we talk now, also Burundi has 6 confirmed cases and 1 person has died from COVID-19. Looking at South Sudan, they have 4 cases of COVID-19. Now, globally, about 2.2 million cases have been confirmed, and among these, 571,000 have recovered from COVID-19, and 154,000 have died from COVID-19. Now that is pretty much the statistics that we have currently in regards to those that have had confirmed cases of COVID-19 and those that have died from the pandemic. In Uganda here we have 55 confirmed cases of COVID-19, and right now we are going to take you over to the Health Minister to address the press in regards to COVID-19.
Mr. Zikusoka, and thank you once again for giving us this opportunity to speak with you. With me I have the World Health Organization country representative, Dr. Jonas Tegeny, who is on my right-hand side, and I also have the CDC country director, Dr. Lisa Nelson, who is on my left-hand side. But I also have a team of scientists who will be responding to your questions today. And I will also introduce the scientists who have been supporting this response. As many of you are aware, this is a new virus, and we can only run the response with guidance from the scientists. And I will start by introducing Dr. Jane Nachibuka. And we have Professor Rhoda Wanyenze. We have Professor Dennis Byarugaba, Professor Pontiano Kalebu. We have Professor Muwezi Winston, Professor Sengoba Freddy, Dr. Henry Kajumbula, Dr. Misachi Wayenjera, who is the chair of the scientific committee. And then allow me also to introduce the Director General, Health Services, who is overseeing the response, Dr. Henry Mwebesa, and the Incident Manager for COVID-19, Lieutenant Colonel Chobe Henry. Okay. I will now give my statement, and these scientists will respond to your questions. As you may all recall, Uganda registered her first case of COVID-19 on Saturday, 21st March 2020. As of today, the country has a cumulative number of 55 confirmed cases of COVID-19. All the confirmed cases were admitted in Entebbe Grade B Hospital, Mulago Hospital, Adjumani, and Hoima hospitals. To date, 20 patients have been discharged. Entebbe Grade B has discharged 7. Mulago National Specialized Hospital has discharged 11 patients. Adjumani has discharged 1 and Hoima 1, leaving a total of 35 active cases. Uganda has not registered any COVID-19 related deaths. Allow me in a special way to appreciate His Excellency the President of the Republic of Uganda for the swift and decisive way in which he has commanded and guided the National Task Force for COVID-19 including issuing the 35 guidelines for prevention of infection to the general public to follow and adhere to. His Excellency has addressed the public several times and repeatedly emphasized on prevention and suppression of transmission. I would also like to appreciate the health workers at the front line in this battle. You're doing a good job in spite of the challenges, and you're highly valued. I cannot forget to thank the communities, the entire population of Uganda, for your resilience, support, and cooperation. The direction in which this pandemic will move in Uganda will be determined by you, your behavior, your support, and your cooperation. I have no doubt that you have been listening to His Excellency the President, following his advice and guidelines given to you, and also guidelines given by the Ministry of Health, and listening to what is happening throughout the world, and are ready to ensure that COVID-19 does not spread to unmanageable levels in Uganda. Following the declaration of the 14 days lockdown, the Ministry of Health developed a lockdown strategic plan with 6 action points aimed at combing the country to ensure that all potential sources of infection are identified, tested, and managed accordingly. The action plan included the following. Number 1 was follow-up of contacts and alerts and testing all. Number 2 was testing all those in quarantine and discharging those who test negative and have not had any other contact. Number 3 was supporting decentralization of surveillance and management of patients to the regional and district levels. Number 4 was enhancing risk communication to regional levels, district, and the communities. Number 5 was screening and testing of all incoming cargo drivers from the East African community areas. And number 6, identifying, mapping, and testing all returnees who came back between the 7th and the 22nd of March, when the airport was closed. I will now highlight the achievements that the ministry and partners were able to gain during the 14-day lockdown period. And I'll begin with management of confirmed cases. As of today, Uganda has a cumulative number of 55 confirmed cases. Of these, 20 have recovered, while 35 are active cases. Please note that this is a cumulative number comprising of recoveries. Active cases are the cases that still have the virus and are undergoing treatment at the respective health facilities. From the onset of the pandemic to date, a total of 9,975 persons have been tested, of which 9,920 are negative and 55 were confirmed positive. I'll give an analysis of the confirmed cases. Of the confirmed cases, some had a history of travel, and those are 46 in number, and they are broken down as follows. 30 were identified from the quarantine sites. 5 were identified directly from the airport. 12 returned following the appeal to all those who returned from Dubai to come for testing. And 1 is a truck driver identified at Malaba point of entry. 7 persons have no history of travel, and these are broken down as follows. 1 is from Luengo district. The other is from Chengera, Nkonkonjeru. We have 1 from Chanja, 1 from Kayunga, 1 from Katabi, 1 from Ajumani, and 1 from Iganga. All staff in Entebbe Hospital who have been taking care of patients have been screened for COVID-19 and all tested negative. This means they are appropriately following the infection control procedures in the isolation facilities, and a repeat test will be done after 2 weeks. All staff from Mulago are also undergoing testing. Before we discharge patients to the communities, we carry out a number of procedures which I will highlight. We counsel the communities where the patient is going to avoid stigma and discrimination. Psychosocial counseling is also provided to the discharged patient, and a 14-day follow-up of the person is carried out to provide psychosocial support and risk communication. The discharged patient is given a discharge certificate, a result slip of the last test, and standard operating procedures comprised of the do's and don'ts. I will now move to the 6 strategies, beginning with follow-up of contacts and alerts. A cumulative total of 1,396 contacts to the confirmed cases have been registered since the declaration of the first confirmed case. 1,078 have completed their 14 days of follow-up screening or testing. 317 contacts are still under follow-up. So far, 1,246, that is 89% of the contacts, have been tested after 10 days of daily follow-up. All contacts to the confirmed cases are followed up daily by our surveillance officers for 14 days. If they develop signs and symptoms of COVID-19, they are tested, and if found positive, they are isolated for treatment. Institutional quarantine. Institutional quarantine was an intervention that greatly limited the spread of infection to the communities. In spite of the challenges, 30 of the cumulative 55 confirmed cases were identified from institutional quarantine. The cumulative numbers of persons quarantined to date is 2,661 countrywide. Currently, a total of 437 people are still under institutional quarantine, and the numbers are broken down as follows. 30 are in Entebbe, 53 are in Kampala, 354 are in upcountry sites in various districts. I'll now move to the high-risk returnees. A total of 18,860 high-risk returnees between 7th to 22nd March were identified through the information obtained from the flight manifest. From the 6th of March to the 16th of March, several people returning from the category 1 high-risk countries were put under self-quarantine and successfully followed up. Those who came in from the 17th to 22nd March from the high-risk countries were put under institutional quarantine. A good number came back following the call from the Ministry of Health to those who returned from Dubai. Of the 9,975 tests done to date, 2,878 are from the border points of entry, 700 are contacts, while 6,397 are part of the high-risk travelers. In total, over 8,000 high-risk travelers have been identified, tested, and cleared. Others have been reached during follow-up and contact tracing. The process of reaching out to the returnees is still ongoing with support from the telecom companies. A nose and throat swab and blood samples may be removed from the persons once reached, depending on the assessment by the surveillance officers, to rule out the possibility of asymptomatic infections. I request those not yet reached to be patient and cooperate for the exercise to be completed this coming week. I'll now move to the third strategy, which is support to districts and regional referral hospitals to enhance their capacity to respond to the pandemic and offer basic medical services to the population. Each district has been provided with funds to facilitate the various functions of surveillance, contact tracing, sample removal and testing, quarantine, risk communication, and case management. Training of district and regional referral hospital teams on COVID-19 preparedness and response is being rapidly undertaken. The exercise includes training of case management teams and setting up isolation facilities. The Ministry of Health has deployed a team of 4 specialists per region, comprising of a senior clinician, a senior Ministry of Health officer, and 2 epidemiologists. These teams will carry out the following tasks to support the districts and the regional hospitals. Number 1 is train the regional and district health teams to build their capacity for handling COVID-19 cases. 2, support coordination of information and prompt reporting to the Incident Command Center. 3, support the districts to carry out surveillance and contact tracing within the communities. 4, support risk communication activities throughout the parishes and villages by ensuring that the district leadership engages the village health teams. 5, support the districts to ensure smooth continuity of the other basic health services for all ailments. All districts and regional referral hospitals have received protective wear, sample removal kits, and other supplies to enable them safely remove samples and send for testing. Guidelines for use of protective wear has also been provided to the districts. I'll now go to the 5th strategy, which is risk communication. The district leadership is being supported to disseminate preventive messages and other key messages related to standard operating procedures for many areas as prepared by the health promotion and communication teams of the Ministry of Health and partners. These messages have been translated into 7 different languages. The districts are encouraged to use all channels of communication, including the village health teams, to disseminate preventive messages and information. I'll now move to the 6th strategy, screening and testing of cargo transporters. The Ministry of Health began screening and testing truck drivers across the 53 points of entry. To date, a total of 2,878 samples from truck drivers have been screened and tested. Of these, 1 Ugandan truck driver tested positive, while the other 2 were from Kenya and Tanzania, respectively. On average, 2,500 trucks cross the border points daily. In light of the high numbers at the points of entry, the Ministry of Health, working with the districts, is training more health workers and will increase the number of health workers manning these points. The high number of truck drivers crossing into the country will require a substantial amount of test kits. Further discussions will be held with the East African Community member countries on how to handle this area. I am aware that many of you have been questioning why we do not hold the truck drivers until their test results are returned. And I'll give a few answers to this. Number 1, these truck drivers or cargo drivers are transporting critical supplies that could save many lives during this lockdown, both locally here in Uganda and regionally within the East African community. 2, if we hold them at the borders for a long time, crowding occurs. Crowding is a risk factor for transmission of COVID-19. Standard operating procedures have been developed to allow for easy tracking of the truck drivers. They are also given the do's and don'ts guidelines to follow and strictly advised not to interact with any of the communities along the way to their destination. Implementation of the above 6 strategies is still ongoing. Subsequently, on the 14th of April, following the end of the 14 days lockdown period, His Excellency the President of Uganda declared an extension of the lockdown for an additional 21 days, from the 14th of April to the 5th of May. I will now go to the 21 days lockdown. And I'll start by giving a reminder of why government undertook an extension of the lockdown. The purpose of the lockdown, or extreme social distancing, is to suppress transmission by reducing the number of people any undetected yet positive case in the community can infect. The goal is to ensure that each confirmed case infects less than 1 person on average. Justification for the 21-day extension. Evidence available from the response to the COVID-19 pandemic in countries where lockdown was delayed or shortened, and I've given examples: the United States of America, Italy, Spain, and other countries in Europe, compared to others, South Korea, Singapore, Hong Kong, Japan, and China, where lockdowns were implemented early in the pandemic and prolonged for over 2 to 3 months, shows a better outcome in countries where time was taken to fully implement activities which were identified to reduce suppression of the virus. And as I earlier on indicated, we had not yet implemented the 6 strategies to 100%. Number 2, experience from the Asian countries that have flattened the curve or kept their infection rates very low shows that very strict tracking, testing, and quarantining of exposed individuals and their contacts has a big impact on the spread of the disease at community level. Number 3, the 14-day lockdown strategy had only been partially implemented. And number 4, extreme social distancing measures for the uninfected people reduces the mixing with infected people and protects them as the surveillance system operates to track and quarantine all exposed individuals. More emphasis needs to be put on this. Number 5, the lockdown reduced the pressure on the surveillance system and the health system by keeping the numbers low. The country must maintain the low numbers and low rates of infection. When the numbers of exposed and infected individuals grow so fast, the stress on the system is huge and the system cannot cope, as we have seen in several countries in Europe and the United States, where the response was initially slow. With the potential sources of infection still not fully identified, and with the numbers of confirmed cases in the neighboring countries rising, it would be too soon to lift the lockdown. So what is government doing in the 21 days of lockdown? I will now explain what we shall focus on in the 21 days of the lockdown. The Ministry of Health will ensure that all the 6 action points are implemented to 100%. Focus will be put on the following areas. Number 1, screening and testing all the cargo transporters. Working with Uganda Revenue Authority and the Ministry of Transport, our surveillance officers have been oriented on how to track the cargo transporters. Standard operating procedures, joint border clearance forms with details of the truck drivers indicating their origin and destination have been developed for them to fill. Truck routes have been mapped for the cargo transporters to follow without deviation, and a tracking mechanism is in place for the surveillance officers to quickly track them and return them to the country of origin or quarantine them accordingly. 2 mobile PCR laboratories have been procured and will be received in the country tomorrow, Sunday 19th April 2020, and after commissioning will be deployed at the congested border points to quicken testing and return of results to the cargo drivers. I appeal to all of you who live along the roads, followed by the truck drivers, including the women who interact with them for different purposes, to stay away from these truck drivers. During this period of lockdown, please do not accept visitors into your homes, not even your neighbors. Ensure adequate physical distancing with people who do not live with you every day. Stay at home. Avoid trading centers and other business places because you do not know where your friend has been or whether he or she is safe. Those who defiantly use these trucks as a means of transport during this lockdown period are warned to stop these unlawful activities. The other area that we shall focus on is to routinely test all health workers who are carrying out surveillance and managing COVID-19 positive patients in isolation. An inventory of health workers responding to this pandemic has been generated and testing has started and will be carried out every 7 to 14 days. As I indicated earlier, we have screened all those in Entebbe Hospital, tested all those in Entebbe Hospital. Testing is ongoing for those in Mulago, and we shall begin testing the surveillance officers. The other area of focus will be testing all incoming people, like the UN staff who come in to give support. We shall identify illegal entrants into the country through the porous borders with support from the communities and test them as well. The other area of focus will be to enhance risk communication to ensure everybody is aware about the potential danger of COVID-19. The Ministry of Health would like to hear from you on a weekly basis. The ministry website and Twitter handle will publish an online survey to obtain feedback from you about our response. We want to encourage the village health teams, once we have empowered you with megaphones, to move through the parishes and educate people on COVID-19 so that the communities can help us to identify those who join you illegally through the porous borders. The other area of focus will be to ensure that the country is cleared of all pockets of transmission. In this regard, the ministry will carry out a rapid assessment survey focusing on previously known foci of transmission, and those are the areas where we have had contacts and also points of congregation of the trucks along their way to their destination. I will now speak about essential medical services. I appeal to all health workers and all health facilities to continue offering essential health services. Systems to facilitate patients to access services have been clearly communicated by His Excellency the President. Kampala Capital City Authority should ensure that they publish all their routes and the necessary phone numbers for the population in Kampala to access transport to health facilities. All the district health officers are again reminded to ensure that transport is available for the sick and the vulnerable women and children to access health facilities, and funds have been provided towards this. The Ministry of Health is in the process of deploying the vehicles donated from the various stakeholders to the districts that are largely lacking transport facilities to support this activity. Let us work together to provide the much needed services to our people and reduce the non-COVID-19 related mortalities and avoid reversing the gains that we had made. I'll now speak about the welfare of health workers and frontline workers. The Ministry of Health regrets the delay in the payment of allowances to health workers and frontline workers in the COVID-19 response. We're in the process of ensuring that these allowances are swiftly paid after receiving the bank account details of the health workers in this response from their respective supervisors. The Ministry will also ensure that health workers and frontline workers benefit from the donations to the COVID-19 response, and this process has already started. Update on research. Scientists, and again I introduced them to you earlier on, supporting the government in this response, have prepared over 30 protocols for research to answer some of the questions that the communities and ourselves continue to ask regarding this pandemic, and more especially as this is a new virus. So all these research protocols will be undertaken and evidence will be provided accordingly. As I conclude, I would like to, in a special way and with deep appreciation, recognize the tireless efforts of the health workers, the general public, the private not-for-profit and private service providers. I would also like to appreciate all the people who have been donating generously towards this cause. The Ministry continues to appeal to the general public to remain calm and practice the preventive measures. Wash your hands with soap and water or use an alcohol-based hand rub at least 3 times a day. Maintain your social distance. Please maintain your social distance. If you have flu-like symptoms, cover your nose and mouth with a mask. To report any suspected cases of COVID-19, call the Ministry of Health toll-free lines on 0800 100 066, 0800 203 033, or 0800 303 033. You can also call the shorter toll-free code on 919. Residents of Kampala are advised to call 0800 990 000 or 0204 660 816. I thank you all.
Well, thank you so much, Dr. General Acheng, the Minister of Health, for that very comprehensive and detailed update report on the situation of COVID-19 in the country. I just want to commend you so much and actually say you've basically answered many of the questions, but because we are members of the fourth estate, there will still be questions that will come to you as a minister and also to the scientists here, even when many of the things that we wanted to know have been captured in your update. We thank you so much. Now the press is here with us from different stations and media houses that will have an opportunity to ask you, but coming from me, Honorable Minister, We have seen Uganda try to contain this particular disease here, and when you look at the tally in the region, we're trying to really work very well compared to all the other countries, especially in the region here. And because of that, Ugandans do appreciate, yes, that the lockdown and the measures have actually helped us contain it, but they think government should possibly try to loosen the grip a little and start to do the opening up. When that happens progressively, how do we intend to get back to normal life? What shall we start with? How do we do it? Shall we open up in one go, or we will do it just like the lockdown came to us? I'll also ask members of the press here to come and ask a few questions, and maybe still to the scientists who would just love to know from you. We know that flus in the world have actually been the biggest pandemics, epidemics that have rocked the world in different centuries. Has there been a particular cure of flu that we can actually look to as we wait for the vaccines and the cures that we expect to come sometime in the future? Members of the press, Walter Mwesige from NBS, I beg your pardon, from NTV is actually here. You're very welcome. And all others, by show of hands. Yes, Namuli, as usual from NBS TV, get ready. There's a hand behind there. What house is that? From? Which house is that? I have not heard you. What does it say? Oh, somebody from Consumers something. They will introduce themselves when they get here. I haven't heard you. Yes, Walter, make your question very brief to whoever you want to ask here.
Thank you very much. I have a couple of questions, very brief indeed. We want to know where the Tanzanian truck driver who tested positive is, and if he has been returned to TZ, what's the explanation for him being returned to his country? We had also a baby who came from Iganga. The explanation some time back was the results of one of the parents were borderline. We want to understand the status today, and if UVRI has made any improvements, considering the fact that they are dealing with large numbers of truck drivers tests currently. Then what steps are being taken to stop the truck drivers from spreading the virus into the neighboring countries, of course, from across the borders? How many of the 18,000 plus travelers have been traced and tested? And where is Uganda on the community transmission front? What have we learned so far from the treatment administered to our COVID-19 patients and some of those that have recovered in terms of response to treatment? And international experts continue with doomsday predictions for Africa. What do you make, of some of those findings from those experts? Thank you.
Thank you so much, Walter, for that very good question. Namuli from NBS TV, please come and also make yours. As somebody from Consumers here also comes on to ask that question, just be ready. Yes, when you get there, we're trying to keep very safe. Sanitization is very important here. Thank you so much.
My name is Zahara Namali. I work with NBS Television. Walter stole the exam paper that we set as the Health Journalists Network, so he asked many of the questions. My question goes to Professor Kalebu, or to the scientific team. The questions are many. Is Uganda treating the same coronavirus, COVID-19, identified in the other parts of the country?
Thank you so much. And maybe to just add on what Namuli has said, we've also heard that 2, I think, of the 20 recoveries actually claim that they were asymptomatic, yes, but then they say they've never had coronavirus because they did not see anybody treat them. They were told you have coronavirus, then they were told you don't have coronavirus, I think, after some treatment that was not administered to them. We need to learn from you, the experts, what actually this means to us. You're welcome.
Ty James, thank you very much, scientists. Uganda seems to be a very, very special country. Because from your speech, Honorable Minister, you said that Uganda has not yet registered any person dying so far. So I'm wondering, what is Uganda doing that other countries are not doing Like you see the US, many people have died. China, many people have died. And the rest, and so on and so forth. What is really special with you people in the Ministry of Health that other countries need to learn, or even since the WHO representative is here, that other countries need to emulate from us? Thank you.
Well, thank you so much. Maybe the other question also that is coming in, especially to the scientists, we also now looking at the other alternatives now, which is the traditional and the complementary medicines, because that's one of the fields that we're trying to also look into, because when you look at countries like China, India, and everywhere, who are also now trying to think and go to the other alternatives, we hear about this. And because they've told us that herd immunity is actually one of the reasons why somebody can actually contract COVID-19 and they get cured of it. Where is the position of traditional and complementary medicines in this? I will take the opportunity now. Yes, let me invite my sister Naluja from Bokede TV. Welcome.
Navja Shamshad from Bokede TV. Nurses and midwives are some of the health workers on the front line, but we don't see them represented here. Are there any plans of recruiting some of them?
Okay, representations, I don't know whether you've had Naluja. Nurses and midwives are not represented here. Well, the minister will talk to us about that. Any other question before I invite Dr. Message Wayenjera to come? Yes, Emma, the Public Relations Office of the Ministry. You're also very welcome to ask your questions. As doctor, you help me here guide on who takes on what question. As a scientist, you know who is most suited to actually answer which question from the media. Welcome, sir.
Thank you very much. You know, because of social distancing, the number of journalists is limited, but some manage to send their questions via WhatsApp. So there is a question on what we are doing to pick samples from islands, for instance Buvuma, and also what is being done on the water body Lake Victoria, such that it's not being undermined by people to cross from the other neighboring countries. Another question is for the scientists. What research is being undertaken to develop a drug or vaccine in Uganda locally? Are there any studies already so far commissioned? Thank you.
Thank you so much. Dr. Message, I will invite you to actually come and guide us on who answers which question and how, because as an expert and as a scientist, you know who is best suited to answer what type of question.
Thank you, Jagenda. I think before we start, it is important to again appreciate that the national response is multi-sectorial, and the National Task Force on COVID-19 is led under the Prime Minister's office, and this is a sectorial strategic response by the Ministry of Health. The scientists I have here are chairing 8 ad hoc committees. The first one is on biology and pathogenesis, epidemiology and surveillance, case management, diagnosis, psychosocial support, policy implications, research, and infection control. I'm just trying to let you know that we are trying to cover the entire big picture of the disease. As usual, our role is to shield the minister from the technical operational questions, except the strategic managerial ones, which, thank God, this time around we've not had many. At this juncture, I will request the question you asked just to echo. Lockdown helped, but when do we plan to loosen the grip? And Professor Rhoda Wanyenze, probably you come and talk about the checklist that we have developed, and aligning with the WHO advisory on when to loosen the lockdown and how it's supposed to be done. Please, you're welcome.
Thank you. Let's welcome Dr. Wanyenza just right here where the Minister has been starting to speak to us. Dr. Rhoda, be assured that you are live on all TVs in this country, so you're speaking to the whole country.
Thank you for the opportunity to speak to all of you. The Minister explained why the lockdown is important. And just to recap, there are two broad areas where the lockdown helps us to manage the response. One, we would like to be able to interrupt the transmission, the rate of mixing, being able to track those that are infected and being able to keep them away from those who are not infected. But we also have preparatory activities that we have to undertake to be able to respond to the epidemic very well. Some of these include making sure that our system is very well prepared to manage the epidemic. We need to prepare to do a good tracking. Should we lift the lockdown, for example, we might have cases, let's say, across all the country. How do we actually track them and be able to get them out, test them on time, return their results and isolate them? So we need to have that system ready. Then when we do lift it, and some people will become sick, we've seen this across all the countries. Yeah. We are also looking at the system to make sure we are prepared to manage the cases very well so that we minimize mortality. Because when the numbers grow so big, and there was a question related to that from one of the journalists, then the system doesn't manage them well, and this is what partly causes death. They don't come in quickly, we don't have enough facilities. So how do we prepare then to lift the lockdown? We have a series of issues that we have listed, and recently there has been a guidance from the WHO with 6 points. This guidance came out because there is a growing realization that countries are struggling with how to actually lift the lockdown, and when you do it too early you begin to have a rebound. The Minister mentioned some other countries like South Korea and others that we've been monitoring, and we realize that they are beginning to get numbers going up. So we want to be able to prepare well so that we can maintain the control but also provide good care. And some of the examples of these issues include, for example, how well are we prepared to do our surveillance, contact tracing, testing, as well as isolating? How well are we prepared for care, for example? Then there is the communication. We need to be able to reach out to all of you out there so that you understand your role and how you can contribute to this in terms of protecting yourselves and staying safe, in terms of supporting others. There are issues around stigma for those who are infected. We need to be able to prepare for that. So there is this checklist that we've developed that is guiding what the Ministry of Health is doing, but to also note that there are issues that go beyond the sector, like Misaki has mentioned, the health sector, that also need to be able to be handled. For example, if people are going back to work, how safe is the workplace? If you're going back to the market, how safe is the market? If you're going back to your office, how safe is it? And how are you going to keep yourself from getting the infection? So there needs to be other protocols and preparations for lifting. How do you travel to work? There needs to be a plan for how you can safely travel within public and private means as well. So we need to prepare this so that we don't suddenly lift the lockdown and then we lose all the benefits that we have had from the lockdown. It's a very comprehensive list, and once we follow this and do it well, then we should be able to handle both in terms of controlling new infections but also being able to manage those who are sick. Thank you.
Maybe just before you step down, will the opening also be progressive like we did the lockdown, or it will just come in one instant?
We are studying what other countries are doing, for example, and searching the literature in addition to the guidance that we have from the WHO. And what we notice is that the lockdown lifting should not happen as abruptly. There needs to be some order that allows us to be able to manage what is emerging and be able to quickly respond. respond. For example, I'll just use one example. If we decided that we are lifting for more people to go back to work, which sectors could we start with?
Exactly.
And how do we actually make sure that those sectors are prepared to receive and manage, well, so that people are not getting sick within the workplace? So we need to be able to plan for that. And then, of course, there are other areas where we are worried about vulnerabilities. Do we keep away some people while we allow others to go back to work? Like we have seen in several countries where the elderly are advised to keep away still while some other people go back. So it has to be orderly, and it has to be informed by the science in terms of who is most vulnerable and who do we need to continue to protect as we lift the lockdown.
Thank you, Doctor.
Thank you, Professor Roda. Professor Roda is the chair of the Epidemiology, Surveillance and Modeling Ad Hoc Committee. There was a question that you raised, Jagenda, which is flu is in the world. Flu has been around in the world for a long time, but is there any cure for flu? And I'm going to ask Professor Dennis Byarugaba, who is the chair of the Biology and Pathogenesis, to come and answer this question. Please. Professor Byarugaba has been doing work on coronavirus for years. He is actually in charge of the flu surveillance program in the country. So that's the reason I'm asking him to come and answer.
Thank you very much, Misach.
Doctor, just for guidance, you're live on all these TVs in the country, so I beg that you look into the eye of that camera for you to be able to communicate with the people and you don't mind about the monitors that are in the studios here.
So thank you very much. The question of treatment for flus, you very well know that flus have been around for quite a long time, and they have caused tremendous damage, killing up to millions of people. Unfortunately, there is no cure for viruses of the flu type, but there are vaccines against flu which are available that are routinely administered, particularly in the temperate regions. We also have them for special grades of people in the temperate regions like Uganda, for those who are working in laboratories, but also the elderly. Unfortunately, this hasn't been extensively rolled out to cover many other people, but this is the way that these vaccines have been used for management of flu. During the 29 pandemic, there were attempts to get treatments for flu, and some of the treatments, including Tamiflu, were made available. And yes, so if there are any pandemics of that nature, then they can be safely treated with those antivirals. But right now, the best way to manage these viruses is to use vaccines. Unfortunately, there are no current vaccines available for coronaviruses, and until they are available, we have to adhere to the measures that we should be following to ensure that we avoid the disease by prevention measures. Thank you.
Okay, thank you, Professor. Before you go, can you please tell the country about the network of the influenza surveillance, national surveillance program?
Yes, we have been running an influenza and respiratory viruses surveillance program together with the Uganda Virus Research Institute for the last over 10 years. This started at the time when there were threats of the pandemic of the H1N1, if you recall, around 2003, and we started our program in 2008, and this has been running. Currently, we collect samples from 3 Sentinel sites. We started with 5, but when the pandemic reduced, we decreased this to 3 Sentinel sites. Unfortunately, the coronavirus or the COVID symptoms actually are flu-like symptoms. So we expect that our surveillance teams will be able to pick up some of these cases, and we'll be able to test them and also hand them over for management by Ministry of Health. So yes, this surveillance program is there, and we are hoping to take advantage and strengthen it to be able to continuously do surveillance for coronaviruses.
Okay.
Thank you.
Thank you. Thank you, Professor. Walter Mwesigwa, NTV, asked a series of questions. Incident Commander, please, this is yours. Where is the TZ driver? And why did we repatriate the TZ, the Tanzanian driver? That is a question that was supposed to be addressed to you. I think that is, where's Kano, you're welcome.
Thank you so much.
And I think you will also answer the steps to trace this driver. I think that is what steps are being taken. I think that was another question you asked.
Yeah.
To regulate the movements of drivers, yes.
Yes, a 34-year-old truck driver from Tanzania, through routine screening that we've been undertaking, was identified at Mutukula, tested, and the sample last evening came out positive. He was identified through a tracking system at Karuma and was brought back to Mutukula. As of now, he's on transition to his home country. The reason why he's repatriated, he's taken back to his country, and this was in agreement with the regional ministers of health. And the reasons of how we are tracking them is that at each border point, all the truck drivers, we subject them to clinical screening, that is finding out the symptoms and also taking temperature. But in addition, we take off a sample. URA technology, we have URA uses technology to be able to follow them up wherever they are, and they go to specific places, and they are not allowed to stop at any one point, and they only stop at designated places. These are Karuma, Kona Kamdin, Soroti, Lukaya, Liantonde, and Mubende. So I think that will answer the question.
Yes, I think, thank you, Kano. Kano Chobe is actually is a medical doctor. He's an epidemiologist, actually a senior consultant epidemiologist, and he's in charge of commanding the national task force response in the ministry. Thank you, Kano.
I would also want to answer the question of the girl, but without
please, yeah,
divulging details of the patient. She's doing better, and we think she'll be discharged in a short time.
Thank you. Thank you, Kano. We will continue with the answers along the way. I think, Professor Pontiano, I'll ask you to come up and answer the issue of the baby from Iganga, the borderline results, but also, yes, he's not completed it. It has to be completed. And also, the issue of, there was the issue of the borderline results. Yep. But also, is Uganda treating the same strain, same virus? Okay. And Professor Pontiano, I think you better announce the good news to the Ugandans.
Okay. Yes. Thank you very much for these questions. As you have heard, the Iganga baby was discharged. The results were borderline. It was safer to treat her as somebody who is infected, but we did modify on our testing so that borderlines are repeated, and we give results after a repeat. But for this particular case, we took her as somebody positive. It is safe, it was safer, and the good thing is that she is recovered, and she's, I think, doing well. So as you said, how have we addressed it? I mentioned last time that we have adjusted our cutoffs, but also to make sure that those individuals who are borderline, we do repeat, as I've said. So we don't have any problem anymore. The question from Zahara about are we treating the same virus? It's an interesting question because I'm happy as Dr. Misaki has mentioned that our team at Uganda Virus Research Institute, led by Professor Matt Cotton, working with the partners, Medical Research Council and London School of Hygiene and Tropical Medicine at UVRI in Entebbe, have started sequencing the virus. And we have already started getting the results of the sequence of the virus. And sequencing means to really map the virus, how it looks like, its genetic makeup. And interestingly, the genetic makeup of this virus resembles where the travelers are coming from. So if a traveler came from UK, the virus is very much close or clustering with the virus in the UK. If they came from Dubai, they cluster or they're very near the virus that is coming from Asia. So, which is very good news in that what we are seeing is not much different from what others are seeing. So the virus looks the same, although it varies a little bit depending on where you come from. When you look at the way it has been mapped, the viruses you can see clearly coming from UK, from USA, from Asia, that have slight differences. So our viruses match those viruses where our travelers are coming from. So this is the genetic makeup. It's not the same as looking at the biological, how the biology of the virus is. Is it more transmissible? Is it more pathogenic? Those studies have not been done. However, the genetic makeup of the virus gives us an indication that the viruses we have will not be any different, even biologically, from the viruses from other countries. So I can more or less say that we're having the same viruses. Yeah, they're not different, and we need to manage them in the same way.
Okay, Professor, since you are leading the diagnosis arm, what is being done for the islands, Lake Victoria and the water bodies?
I think for the islands, in case there's any suspect or in case there are any samples, they are treated in the same way, using the systems that are in place, whether it's hubs or using the alert system, and the samples are sent to us. I'm not sure, I don't have this information whether we have had samples from the island, but in case it happens, there are systems to track and to send these samples to Uganda Virus Research Institute.
Okay, thank you, Professor. I think the key thing here to note is that we already have sequenced the genome of the Ugandan isolate strain of the virus, and that is very important in terms of us understanding the biology. I think Professor has something more to say.
I'm just told that, we have got samples from Kalangala. I want to talk about, maybe briefly, the mobile lab. This morning, the mobile labs have actually crossed the border. And our colleagues from the ministry and from the virus and CPHL are now moving with the mobile labs, and they'll be here later today for commissioning. When they come, they use in the lab, again, they have real-time PCR. Yeah. So what we are going to do is to make sure that it's functional, because you may have the mobile, but you need to see that it's functional. You need to see we have the reagents. Then we're going to test that whether the mobile lab gives us the same results as the technique that we have been doing. We hope it will do the same. If it works, then this mobile lab will be dispatched to the borders of entry, and it will be easier to have results quickly. So there are 2 mobile labs that are coming, and we hope more will come.
Okay, thank you, Professor. Dr. Jane. Dr. Jane is one of our senior consultant intensivist, actually in charge of the ICU at the specialized hospital in Mulago. She heads our ad hoc committee on case management, and this is the team that has been working around to make sure they develop case management guidelines, and also advise the ministry how these can be deployed. There was a question about lessons from the treatment of cases. What lessons have you learned? And also, maybe you answered the question of the fact that I think there are cases claiming they were never given any treatment, and yet they recovered. Thank you.
Okay, thank you very much. We've had cases for a while now, and when we first got the case on the 21st of March, that particular patient was admitted. We didn't know how the patient would behave, and since then we've had 55 patients. Majority have been admitted at Mulago Hospital and Entebbe Hospital. But just as you heard Professor Caleb was saying, the strain that is out there is what we exactly have. However, our patients have only presented with, they are either asymptomatic, that is they don't manifest with any signs of disease or symptoms. Then we have those who are moderate, a few who may need oxygen. So we also know globally from the literature that at least 80% may be mild or not even have any complaints, so they may get better. And out of these, we also have 20% who get severe disease and may need to be admitted in hospital, and 5 of who may need to be admitted in the intensive care facility. But in Uganda at the moment, we don't yet have that. Out of those that were admitted, we have only asymptomatic patients, then those who are mild, and we are also starting to discharge some of the patients. However, what these patients are receiving across the board is supportive care, and some of the drugs that have been put out there following extensive literature research include chloroquine or hydroxychloroquine. Now, chloroquine is one of those drugs that are very well known to Ugandans, which were used to treat malaria, and they've been found to have some activity against COVID. They are antiviral. They prevent replication of the virus. So these have been attempted on some of these patients. However, we've put together a comprehensive treatment protocol for the country that is going to be used in a research environment, and this will include giving patients different support based on their categorization of the disease. So for patients who are asymptomatic or who are mild, they will receive hydroxychloroquine or chloroquine. So some of these drugs, unlike hydroxychloroquine, which is still available on the market because it treats other diseases other than malaria, chloroquine itself per se had been phased out and other antimalarials had taken ground. But as we speak, it's a drug that most Ugandans way back used to take for malaria. So in some of the cases in our facilities that have used chloroquine, they are not reporting any adverse events apart from some mild nausea almost nearly around day 4. But other than that, they haven't yet encountered any other problems. But in a research environment where monitoring will be done, comprehensive treatment protocols have been put out. So those who are mild will benefit from the chloroquine and other supportive measures, including vitamin C and zinc. And if you have a temperature, then you'll benefit from Panadol or paracetamol, which reduces the fever. Then as you progress in severity of disease, you may need oxygen. So oxygen can be dispensed in various ways, and also that is put in place. If you're severely ill, it may require admission to the intensive care unit, and that's why there's a preparation or the lockdown is also helping us to put together critical care services so that should we have such a patient, the patient will be managed adequately. So as we speak now, we've only registered mild, moderate, and probably 1 severe case. And out of those, so far Uganda has not registered any death, like the minister said.
Okay, thank you, Dr. Jen Nakibuka. I think we appreciate that.
It is the same question. Exactly the same question that Dr. Misach wants to bring on to her.
No, there is no. I think that is all.
The research that we talked about.
Well, the aspects of research. Okay, please go ahead and talk about the trials. There's a question about someone who complained that they never received anything. but they got well.
Okay. So just like we are saying, this is a new disease, but out there, like we said, some people may not present with any complaint whatsoever, and they are bound to get better. However, it's some of these kind of patients that may be very, very dangerous to the public because they continue to shed the virus. And if you're in the community and you're shedding the virus, then you can easily transmit the virus. So it is possible that without anything, these patients would actually get better.
I think the key thing to understand is that this is done within the setting of care. The doctors are watching how a mild case progresses. Does it progress to a moderate? And I think we've had Mulago had a case that almost went into severe and what needed a ventilator, but they managed to bring that case back. Maybe Jane, you talk about that. But
okay, there. Maybe what we also need to put into context is that other than COVID-19, these patients already may have illnesses, especially the chronic illnesses like hypertension, diabetes, and all these things will continue regardless of whether you're infected or not. So one of the main things that is where emphasis is being laid is to make sure that all those comorbidities are handled, because it's these that get out of hand and actually may tip the patient over. So there are also patients who may have their chronic respiratory diseases. So when you add COVID to that, they may present severely and also almost tip over. So this particular patient had a worsening chest X-ray findings. However, the patient did not end up in the intensive care unit.
Okay, thank you, Dr. Nakibuka. Professor Sengoba. Professor Sengoba is heading the ad hoc committee on policy implications. In fact, I'm surprised you people didn't ask questions on policy implications. I think the biggest worry we are asking ourselves is a lot of our resources are being diverted to care for COVID. But there was the question on traditional medicines, and I thought I should throw that to you.
Thank you, and good evening, esteemed viewers. So I'll start with a question of traditional medicine. I think at this point in time, we are not in position to recommend tests or alternatives, but clearly it's important that all these go through a rigorous approved process before they are available to the public. It's also sometimes diversionary if the public is misguided in terms of what works and what doesn't work. So it's very important that innovators do find a way to register with government so that their innovations can go through or are guided to the right conclusion. Clearly this, as we said, is a new problem, and even the president, if I could quote the minister, said that the president is very keen to see that as Uganda will become more self-sustaining or sufficient, especially since we've seen that the working technologies are very hard to get from where they are being manufactured. Over 50 countries that manufacture testing kits, for example, have refused to export them to other countries because they need to build enough stock for themselves as well. So as a country, we should be encouraging scientists and including traditional herbalists to go in that way. But I think the point I wanted to raise more is as we deal with COVID, we need to also be reminded as a country that COVID shares a lot of symptoms with things which continue to kill Ugandans and have been here for years. So the cough and pneumonia is one of the top killers for children. Malaria is among the top killers for Uganda, has a fever. Also malaria comes sometimes with a cough, and you may even have diarrhea. So what I'm trying to say that many conditions are out there and still require care. And they would like to encourage our health workers to continue to be available for duty, but also to encourage the clients, especially that who have acute or emergencies, to be able to navigate to reach the health workers. And here I think the message, Mr. Minister, what we've seen, that the president is listened to by everyone, including all officials of other government departments, including security forces. But what we are not sure is happening is whether the president's guidelines are well operationalized so that, for example, communities that don't have a government vehicle easily available can find at least a person in the village with a pickup who can drive them without being stopped to the hospital. And I think as we try to navigate the rest of the time, it would be nice that other sectors and especially other departments and ministries do help us to operationalize, especially this issue of transport, so that patients can find willing and helping hand, or at least people who have transport in the communities, and those communities are able to navigate. What I'm seeing in the on media and the news is that communities are fearing to venture on the roads even when they really need to travel. Health workers are also being stopped, but this, I believe, is now beginning to lessen. But it's important for us to listen to the president, but also we hope the president and the rest of the government officials can help to operationalize the president's statements so that it can help people who are not necessarily at the headquarters or are easy to reach. There are communities in this part of the country where even a border may be very hard to be resident in the village. And mobile phones, we all have them in Kampala, but many Ugandans may even wonder what we are talking about. So these things are not universal. The rest is that we still have diseases that we really need to control. People need to have their refills for especially chronic diseases. We've seen that even those with COVID have to take their medications. I think ways to do targeted delivery for communities to ensure that their refills are given need to be explored so that in the meantime we do not end up with a lot of problems. The other issue which comes up in policy matters, I think, if you allow me to say, private providers, especially health workers in some of these communities, they are also hand to mouth, not as individuals but as businesses. You find that salaries of these workers, especially in the private sector that are not paid off a government payroll, only arrive from the collection of that month. And as we try to maintain stability for care for all of these providers and for the communities, we also need to see how in the current response we try to keep these workers in private and strategic private facilities are well provided for, at least for April and May, should they fail to raise enough revenues of their own to pay their workers. We don't want to have less health workers available for care if we need them. I think I'll stop on this, but maybe just to say that the question I think has been around, and I'm glad that Uganda is doing now very well in terms of testing. We are almost testing over 10,000 people, and as we get more, it's going to be important that journalists especially help us to explain to the rest of Ugandans the issue of how testing needed to be handled, which is really a very dicey issue, because we hear from other countries they are thinking about having to test more as they release the lockdown, but these tests are almost very hard for countries like Uganda to get. I want in this regard to thank our friends WHO, CDC and MRC and others who have actually helped to make Uganda be able to access some testing. But it's not a matter of having money, it's really everyone is looking for them. And it's important that as journalists explain their stories, I've seen stories that seem to not appreciate the fact that this is a global problem. If all countries with COVID are going to look for these same tests, we Ugandans may not be the first one to be served. Thank you very much.
Thank you, Professor Sengoba. I think just to complete this, there are two questions, and these two questions seem to me to be more managerial. As you realize, you're asking why the midwives are not represented here. We are scientists. Certainly in the Ministry of Health, there is a commissioner for nursing who is most positioned at the managerial and strategic level. We are just advising on the science. So the fact that there is no representation here doesn't mean that in the response, Kano Chobe will tell you that he has very many people working under him who are epidemiologists, who are nurses, who are and the same thing with, I think, Jen. So I will Dr. Jen Nakibuka. So I will not go into that direction. I will leave this partially for the management. Just one thing, one question. What is it that we are doing different? Many things. I don't think we are doing anything much different. We are just more keen, maybe. But in the sense to ask that, I think what you see is that whatever is being done by, specifically by the Ministry of Health, is being guided by science and evidence. And maybe this is what is helping us. And in this direction, I just want to ask two people. Dr. Henry Kajumbura, who chairs the Infection Biology Committee, come and try to tell us what we are doing different as far as infection biology infection prevention is concerned. And then we shall hear from Professor Muhwezi about the psychosocial interventions, and I will leave the floor.
Thank you.
Thank you.
Thank you very much, Ms. Aki. What are we doing different in terms of infection prevention and control? Well, infection prevention and control is really a spectrum. First, we need to identify cases early and make sure that they do not transmit the infection. So I think that is one area that we've been very keen on, and I commend the ministry and the incident commander for, well, we've had challenges, but at least I think we've been very keen in trying to identify cases early and taking appropriate action. When we think of infection prevention and control, we think of other elements such as following various events to prevent transmission. And some of these are trying to mobilize the public on issues of hand hygiene, social distancing, cough etiquette. We should know how to cough. So all of these elements have certainly helped us. I think these are the things going out all over the world, but maybe we've been, I think the public itself must be commended for putting in a lot of effort in trying to follow these various guidelines. In healthcare facilities, that is another area where we could actually have foresight. If, for example, a case went into a healthcare facility, that's a potential where we have very many people congregated, the staff, the community who come to look after patients, and the patients themselves could easily be infected. And we've tried to educate our healthcare workers about steps to try and make sure that infections are not transmitted within healthcare facilities. Educating them, identifying any cases very early, particularly ensuring that we screen them for possible symptoms. I think you've seen at healthcare facilities and various other places where people checked for fevers. So some of these steps, and once we identify a case, we take quick action to try and make sure it does not transmit to others. Personal protective equipment has been some of the other critical area, and this is used elsewhere, everywhere, but making sure we use it correctly. We have the right personal protective equipment in healthcare facilities, using masks appropriately, gloves appropriately, other protective wear appropriately. Now, I've seen in the community where we also use gloves. and you can have a person putting on gloves and handling various things. I think that is a danger we should look out for, the way we use gloves. Ideal in a healthcare setting, when we use gloves on a patient, we should use gloves on that patient, remove the gloves, perform hand hygiene, use a different set of gloves on the next patients. In the community, one is using gloves, handling this and that. I think that is an inappropriate thing we are doing. These organisms have been found to stay viable on our skins. Some of the studies have shown that the organisms are viable on the skin for a couple of minutes. Within 1 hour, probably, viable organisms cannot be recovered. But it doesn't mean that we should have organisms. But on the gloves, on rubber, these organisms could stay for a couple of days viable. So we should rethink this habit of using gloves everywhere. And yeah, that is something that we have to look. But in a nutshell, appropriate use of protectives has been one of the things we are doing, and as you've heard from the incident commander, one of the other things that is being, and from the minister, one of the other things that is being done now is healthcare facilities being potential sources where these people, sick people will go who have the COVID, routinely screening our healthcare workers so that they don't fall sick. And in case they don't fall sick, they do not become the source of infection to the community. So I think those are the key issues.
Okay, thank you, Dr. Kajumbura. Dr. Kajumbura is the chair of the ad hoc committee on infection prevention. I think he has led infection control for Mulago Specialized Hospital for the last 10 years or more. Professor Muhwezi, kindly come and say a few things about the psychosocial interventions that have been put in place, particularly as far as the quarantine areas. We had a lot of controversies earlier around quarantine, but I think...
Thank you very much, Misach. What I want to say is that from the psychosocial perspective, it's important to know that anxiety in these COVID times is slightly pervasive, it's high and it's expected, but also to know that a number of people who are psychosocially strong and can easily cope even amidst a challenge like COVID that we are having. However, there are quite a number of people who may not cope, who may need help, who may need a lot of explanation, who may need a lot of reasons as to why this is happening. So these are the ones that may require help. Not very many people may require help. Some who already have pre-existing conditions can get mentally challenged as to require help or to require a counselor to help them. So that's very important. From the point that Dr. Misach has raised about quarantine, I think it's very important to note that this is a new disease and people have questions. And when they have questions, they really need answers. They need somebody to reassure. So reassurance and explaining what is going on, the fact that some people can have the virus but will not get diseased as to enter into an institution like a hospital needs to be explained over and over again, and that helps. But I'm also thinking of at the point of going back home to communities, it's very important to manage that process very well. And there are psychosocial counselors within the task forces that have been deployed and are going to reintegrate or to integrate these people back into their communities so that we dispel rumors, myths, misinformation about the dangerousness of somebody. Because some of the people may not have come back. Those who were being traced may not have come to the quarantines willingly. They were fetched And therefore, there is a fear, there is a worry when they go back and people saw them being taken away. They don't know whether these people are fine. So psychosocial teams going along into communities to participate in reintegrating and resettling the people and reassuring communities. I think our communities need by and large a lot of reassurance about the fact that with following the guidelines as communicated on different times by the Minister of Health, social distancing, washing of hands, you can avoid this virus. That information going out as regular as possible, I think, has been working very well. So there is, in my view, it's very important to integrate a very strong counseling component accompany whatever we are doing, because quite frankly the fear, the anxiety is very high. But I am also aware of the fact that within communities there are people with special needs, special populations. For example, people who live with mental illness in the community, the elderly, the people who have disability, living with disability, somebody who is blind and cannot socially distance from the person who holds the stick for him or her if they are going for a short call or whatever. So there are these special populations that have to be looked out for, and we develop some guidance on how they should be helped to live in this new norm. Ultimately, I look at a scenario where COVID is changing the psychosocial interaction, and we are going to be living in a new norm. And as much as possible, it's important to prepare and train our people to expect now to know and leave it as a norm to wash hands, to regularly to use sanitizers, to distance. This is the new norm, and perhaps as we go on through these extra days of lockdown, this message has to be hammered in day by day. Ultimately, even when we cope very well with this disease, at the end of the day, there will be a change in the social cultural interaction that has always gone on. Some things will have to change because we are going to adopt new behaviors that perhaps hitherto were unknown. And these are some of the things we are looking at and investigating to see how well we can do this. For those who are mentally sick, we think they need to be helped because they are not rational enough given their mental illness, so they have to be helped. These are special populations. I'm arguing that they have to be looked out for and managed according to their unique health challenges.
Okay, thank you, Professor Mwezi. I think it's important to appreciate that these issues have been raised, and we are trying to make sure that they are addressed. The reason we are here is to make sure that you appreciate that there are people thinking behind, that some of these are not neglected. Even when, a lot of people think there are many things that are being left behind, and that's why when I start to speak, I say this is a multi-sectorial. You don't expect us from the health sector to be dealing with the economic impacts of potentially this outbreak. The Minister of Finance and the Minister of Trade should be able to handle that. We are doing our part as the sector of the Minister of Health. I will stop here. I've strategically avoided the doomsday prediction, and this question is not complete ideally. Why? Because Professor Roda will tell you that we should not yet celebrate. We might ease the quarantine and then we begin getting cases. We are just trying to make sure that we set in place measures that will enable us manage those cases when they emerge. I mean, we've seen this happen. Even how long shall we hold on? People keep asking. And these are difficult questions, really. But I think this is the reality, and we will deal with it. I will leave the Minister and the PS to specifically answer the questions around, and the DG to answer the questions around the midwives, their representations, and perhaps I think that was the only question that.
I want to thank you so much, Dr. Wayengera. We thank you so much. And just before the minister comes on, because when she was addressing us, she also gave out a number, and there are questions coming to that number, and I request the PRO of the ministry who shall come and actually share those with us. But before he comes on, there are just a few questions here that will require possibly very short answers. Now, there is one common question that has come from the media or from the public out there, saying, can the ministry help the young man, Mijumbi, the doctor, who claimed to have solutions, who claimed to have some answers, develop a solution as opposed to putting him in prison, which might destroy him? Now, that question has come a number of times. There's also another question that has come on from one of my high school teachers, who says this is to Professor Pontiano. We've seen UVRI doing very well, and we commend you for the work that you're doing. But where do we now put a UTRO then, which is now the coordinating center or coordinating office for the control of trypanosomiasis in the country? Do we think about elevating it or using it at this time to help aid in especially doing the testings, because we've seen them do very well in managing sleeping sickness and Ghana in the country? Then there's one coming in from Honorable Alaso, says, is the minister aware that Ugandans who have been quarantined beyond 30 days are still in hotels and quarantine centers? And these quarantine centers will definitely need money from them, whether not from them, but from government. I think that's very important to respond to. And there is a case in point is Mr. Spire Sentongo, who claims to be threatening to go for a hunger strike if he's actually not let to go out of that. And I just want to make an addendum from Walt of NTV, who also has sent me one here to say 165 people in quarantine in Kalangala are complaining of the very bad condition in which they actually are, and we need an update on that. Maybe to Dr. Lisa of the CDC, this is from me. What's your personal opinion on the current trends of COVID-19? And from what you see, do you envision any country that will be able to actually eradicate this disease by the end of this year? And now, there's also one here on the conspiracy of the G5. We've heard about that. Now we know that this SARS-CoV-2 virus, you've told us much about it, but you also hear there are conspiracies about the 5G network. How true is this, and how can we avoid this? Because we hear this, we need a scientific explanation of the 5G technology that we actually, or that many people have alluded to as one of the causes of this very deadly corona virus. And maybe as Emma steps on, this was about the budget. Our reporter here, Mogoya of UBC, talks about the budget, and he says they just appropriated a budget for you very recently. And how is that actually? Is it enough? Is it helping you? Because we've also seen members of parliament appropriating some money for them, but under the pretext of they gave 128 ambulances to the Ministry of Health, they gave their cars, and I think these are again being managed by themselves, having again given them to you, and this is partly why they're actually asking for 20 million shillings, each of them to run, to manage, to maintain their ambulances that they've given to us. And I think I will now get back to Dr. Wayengera to actually tell me who is most suited to answer those questions as we wrap up. Again, to just remind the viewers, you're all live on UBC TV and all the other media houses that getting this feed live. We thank you so much that you are still with us. Dr. Wayengera, back to you.
Thank you, Jack. And I think, thank you. Some of the questions you've directed, and I will leave them where they are. The budget issue will remain with the minister, and I will leave Lisa's question with her. I will just, as probably before the minister comes, and after Lisa, maybe the WR should speak about the advisory on easing the lockdown. I think that is important to probably the 6 points. But for the start, I will answer the question of the young man, Mujumbi. I think the key question here is this is not a problem of the Ministry of Health. I think this is an issue of Ministry of Science and Technology. It's more regulatory than it affects us, because at the end of the day we are the consumers of the products that Mujumbi claims to have. But at the end of the day there are bodies that govern this, and I think the NDA, you didn't see us at the forefront of this. The NDA stood up and did its job, and that was following, I think, the advice from the Ministry of Science and Technology through the Council of Science and Technology. So that is not really our docket. I will not go into details about that. About the SG technology, I think Professor Dennis Biarugaba, you probably need to reassure people that this is a coincidence in development. There is technology developing, but also then we have this bug coming up, and it's when things occur sometimes together simultaneously, in terms of perception, it's very easy to associate these. And in science, we try to deal with some of these biases, but maybe I'll let the biology person tell you.
Thank you very much. I think this is quite a very clear and straightforward question. The 5G is an IT technology, and the coronavirus we are dealing with is a biological material that we are dealing with. And those are two different kinds of things. So simply put, there is currently no evidence that the two are related. If you indulge into the origin of this virus and how it spread across the world, it has nothing to do with 5G. And so I would really want to dispel these rumors that there is a relationship between the IT technology and the biological virus that we are dealing with. So simply put, that's how I would like to address this. Thank you.
Thank you, Professor Dennis. Professor Pontiano, the trypanosomiasis center, that what are you doing to...
Yeah. UTRO was part of us under the Uganda National Health Research Organization. I think now it's under the Ministry of Agriculture, Animal, yes. Yeah. But we used to be together, and they used to do very, very good work. That's one of the institutions that we need to ensure to see how it can be supported. One of the plans under COVID is to do site assessments of labs, potential labs that can participate and contribute. As we expand, we go out into different parts of the country. And there's a team working with the colleagues at the Center of Public Health Laboratories that is going to do site assessments. I think UTRA could be one of those where we can go and assess what we have and also use this. You know, we want to use also the COVID, also as an opportunity to build capacity. You know, in anything that is of tragic, bad, we use the opportunity. How can we use the opportunity? And that brings me to what was asked about vaccine research, and drug research. I think we need to use COVID also. The president is very keen. He has been contacting us. He has talked to me and others. How do we use COVID to build capacity, even in vaccine research? We are going to use the opportunity. We may not have the vaccine that will address COVID now, but let's use the opportunity to build our capacity. We have capacity that is scattered. How can we bring it together? But as far as vaccines are concerned, I know it was asked by one of the journalists, we are going to use it to build our capacity, but also to test existing products that are coming up. We are preparing. We have protocols that will look at some of these vaccine candidates that may come on. And for drugs, we didn't mention the protocol we are to be involved in, the Solidarity, a WHO protocol that is going to use to randomize our patients in two different arms of treatment using the existing drugs, remdesivir, lopinavir, and also chloroquine and hydroxychloroquine. So we are there. For UTRO, I think it should be on our radar to do some site assessment.
Thank you so much, Professor.
Honorable Minister, through you, I would like to invite the Director CDC.
Dr. Lisa.
Thank you very much. Good afternoon. So I was asked about trends in COVID-19 and whether any country might eradicate this virus before the end of the year. Unfortunately, and you've heard from the Honorable Minister, you've heard from many of Uganda's scientific experts, I think that's very unlikely. This is a new virus. There has been a lot of good research that has already been done and a lot of research that is planned in Uganda. What I understand is that vaccine development is underway. There's at least 2 vaccines in phase 1 clinical trials and probably at least 60 or more that are in the pipeline, but it takes time. I think that I did also, though, want to comment on why, if Uganda is doing a bit better or well compared to its neighbors, what might account for that. So firstly, Uganda has been doing global health security work for many years. The Emergency Operations Center is not new. The laboratory network is not new. And I think that has helped us. I think the early action by the government of Uganda and all of the partners here has certainly helped, and we haven't seen those early measures in some of our neighbors. And the good collaboration and communication. I think all of us working together is really what it's going to take. The reliance on science, and again, you've heard from some of the experts here in Uganda who are part of this response and using science to drive programs. But we have to maintain vigilance, and I think you've heard from Professor Rhoda and others that unfortunately we're not out of the woods yet. We heard from the Honorable Minister last time about flattening the curve, and I think that we are seeing some encouraging signs here, that we maybe have had fewer cases than the models might have projected, but unfortunately this virus is going to be with us for some time, and I'm doubtful that any country will be done with it by the end of the year. Thank you.
Thank you so much.
Thank you, Director. Honorable Minister, again through you, WHR.
Thank you. I think there is a lot of pressure from the public and any nation to lift lockdowns as early as possible. But when we see that a nation has to assess itself at least in 6 areas and see where they are in those aspects. And the first one is that transmission should be controlled if there is transmission going on. The second one is the health system capacity is in place to detect, test, isolate, and treat every case. So having that capacity is required before one says we are out of the woods and should have life as it used to be. The third is that outbreak risks are minimized in special settings like health facilities and nursing homes, or in groups of people which are most vulnerable. The fourth aspect is that preventive measures are in place in workplaces, schools, and other places where it is essential for people to go. So ensuring that the workplace does not become an area for infection is important. Ensuring that we do not expose our children when they go to school. So making sure that those activities are done. And the fifth one is risk that importation risk can be managed. And basically what you see now in Uganda when screening truck drivers is to minimize that risk. So establishing a system where we would minimize that to approaching to zero is the other factor we have to look into. Sixth, but not least, and which is probably the most important, is that communities are fully educated and engaged and empowered to adjust to this new norm. We are not going to go back into where we would hug and shake people. We are not going to see that we have a sneezing or coughing etiquette which can spread the disease. I think those cultural changes, those life changes have to come. Until we have the vaccines, until we have a system where we ensure on day to day these things are there, I think the threat would be there. And that is why we are looking into a specific indicators to allow the ministry to look into and assess the risks before recommending a lockdown. And that we hope the 21 days would allow us to ensure that. Thank you.
Okay, thank you, WR. I think, Honorable Minister, the floor will...
The Honorable Minister wants me still to comment on the doomsday scenario. Okay, let me be... I think most of you are aware of the figures. We are in a situation where we have over 2.25 million people infected or having found to be positive for the case, and over 150,000 people who have died. I think this scenario is also grim for Africa. In Africa, we currently, by today, we have close to 21,000 people found to be positive, with over 1,000 deaths and 5,000 people recovered. If we look into the region, we have 246 cases in Kenya, with 11 deaths and 53 recoveries. Tanzania is 147 with 5 deaths and 11 recoveries. Burundi have 5 cases with 1 death. Rwanda with 143 cases, no deaths, but 65 recovered. And South Sudan, up to now, has confirmed 4 cases with no death or recoveries. While the big neighbor, DRC, has 307 cases, and even today has additional 20, with 27 deaths and 26 recoveries. So what it shows is that Africa might be in a place where Asia or Europe or North America is 6 weeks ago. That 6 weeks gain we have is what we have to take, is very precious. And that's the activities, for example, people were asking why is the number still low in Uganda? Because actions has been taken. Lockdowns has shown to decrease cases and mortalities by up to 50%. Testing helps so that we know the asymptomatic cases do not go into the community and spread the disease. So depending on what we do, we can avoid that doomsday. Maybe that doomsday scenario is no more there because every nation is doing their best to curve this epidemic lower and lower. And moreover, I think the model we are trying to use with Professor Rhoda and her team will look into all these factors and will be able to tell us where we are in the curve. But the good thing about this model is also it factors all what we do on a day-to-day basis so that we can put resources, we can put expectations at a closer to reality. So the doomsday, we can avoid it if we do the right thing. Thank you.
Thank you, WR. Honorable Minister.
Honorable Minister, as you get there, because you might be the last to speak to us, and we just have a few here. Somebody here asks whether Uganda will need a vaccine, and if yes, for what purposes? Because we've also had the vaccine issue play out. And this is also just an advice from somebody who says, instead of incarcerating Mr. Mijumbi, why don't you put him to the team of research to enhance the research? Because it seems like it sounds he also knows something. Incorporate him into the research team to also bring on board what he has. And another here says, could you please just comment on the possibility of using plasma for those who have recovered from COVID to help with the other cases? And another pastor here who does prisons ministry, Pastor Joseph Olowo, says, you've done very well in quarantining and isolating these people. How about their spiritual nourishment? Have you also considered it at this time, or we are only going medicine and health? Welcome, Dr. Cheng, again.
Perhaps I will request the scientists to respond on the use of plasma to manage cases before I come in to answer the rest of the question.
Thank you, Doctor. You're the scientist to respond to that. We've just been told so. You're Dr. Jen. Very welcome. And I think, Dr. Wayenjira, I hope you captured Emma's questions. Emma is a PR of the ministry. I think your questions were captured. You talked about the autopsies. I do not know about this, but because we've not lost anybody. Okay.
Talking about autopsies.
Because we've not lost anybody. Very good. Very good.
There are guidelines
sure.
on how autopsies will be done.
Thank you.
Shall have the bodies. I think Dr. Kajumbura will tell you that. There are some things that are avoided strategically.
Okay. Well, thank you so much, Dr. Michel. I think we can pray hard that we do not even get to a level of autopsies. We need to just agree, pray to God, and we actually avoid autopsies as much as we can. Yes, Doctor.
Okay, thank you very much. Yes, there have been instances where in various countries convalescent plasma has been used, been given to patients, especially those who are critically ill, and to be able to boost their ability to mount antibodies and fight the COVID. So yes, this is being tried in various countries.
Okay. Dr. Chen.
Just one thing, I think one thing maybe I need to say is that
on the microphones, please.
Whether we shall need vaccines, certainly we shall need vaccines. Globally, there had been attempts that were put in place to prepare for this day. We know about the Coalition for Epidemic Preparedness Innovation. They've been running quite very fast with the attempt of trying to produce a vaccine under 16 weeks. This is unthought of, producing a vaccine under 16 weeks and making sure that it's entering human trials. But what I need to say is that Professor Pontiano, working with Professor Vinod Nantulia, in early phases of considering making a vaccine locally for us. Thank you.
Thank you so much, Dr. Bisach. And I think you have the rest of the questions to yourself, Dr. Cheng, as we also prepare to actually end this show tonight.
Well, first of all, allow me to thank the scientists for answering the questions. These scientists are the strength behind the response, because as you know, this response has to be guided by science. And so allow me again to say a big thank you to all of you. I will start with the issue of the nurses. The nurses have not been left out. The nurses are heavily involved in infection prevention and control, management of patients in isolation, management of patients in quarantine, and the acting commissioner nursing is part of the pillars in the Ministry of Health. They are not necessarily on the scientific committee, but they have work that they are doing. Now, the issue of Mijumbi, we need to follow procedures in whatever scientific evidence we are generating. Dr. Mijumbi generated his evidence alone, and he went on air to announce it. So National Drug Authority did what it is supposed to do under the law. So we request Dr. Mijumbi to follow procedures and officially release his results following the laid down procedures for scientific investigations and the evidence that he has generated. On the Ugandans quarantined beyond 30 days in some centers, again, I will repeat what I said earlier in my statement. We have dispatched a team to support the districts to understand who should be quarantined and who should not be quarantined, and also to ensure that people under quarantine are discharged according to procedures. So I do hope whichever districts these people are in, support will be given and they will be discharged accordingly. Now, Mr. Spire is no longer in quarantine. If he decides to go on hunger strike, it will be unfortunate, but I want to encourage him to join support to the response and bring his voice out positively instead of negatively. Quarantining him was for a reason. And now that he is out, he has to join and give support so that together we can ensure that the population of Uganda are protected. Again, the teams we sent to the different districts will be able to support Kalangala to ensure that those people are in better conditions. The issue of the budget, yes, the Ministry of Health has received funds from Ministry of Finance and from other supporting agencies that I talked about the last time. The budget for the entire response for a period of 6 months is 404 billion. We have half of that. We are moving towards the end of the financial year. We are sure that should money be required, it will be provided for accordingly by the Ministry of Finance. So right now, we are not lacking in resources, and we do hope that as we move along, whatsoever we lack will be provided. Regarding counseling, the counselors that are offering counseling have not neglected the spiritual part. I am sure that they are doing it. I am not part of the counselors, so I will not talk about that in details. I would like to say something specifically to the population. Again, we have to take note that the DRC has declared an Ebola outbreak. And the Ebola is in Beni, again very near to the border with Uganda, on the western side with Kasese. They have already reported some deaths. We already have an incident manager for that Ebola. Again, Ugandans at the border with DRC, we have to take note that there is Ebola. So even when we are under a lockdown, please be on the lookout to ensure that people who come in and you don't know them are reported accordingly so that we can take action. Lastly, allow me to appreciate all of you, to appreciate the communities, to appreciate the scientists, to appreciate the National Task Force on COVID response. Again, Ugandans, let us not start celebrating. We already know what is going on in the other countries. We have to take care. We are cognizant that you are living under difficult conditions during this lockdown period. You need food, you need other services, but this is a battle of life and death. We request you to be patient, to hang in there, as everything is being done to make sure that you stay alive, but also address other needs. I thank you and I request you to stay home, stay safe.
Thank you so much, Dr. General Acheng, Minister of Health. We thank you so much for this very elaborate and lengthy